Hello everyone. This meeting is important for me because the participants are included here are very valuable for me, Kerim for example, and in the audience I have very beloved ones watching me, and I'm very proud to be here. Well, our general topics are evidence-based, so I will start with the definition of what evidence-based treatment is. Well, it's like a lightsaber, right? Well, while evaluating evidence-based treatments, we have various methods. One of them is the grade approach. Well, I think it's the most significant aspect because there are lots of studies accumulating. So if we understand what is important, then it will be much more easier afterwards. Because if the journal is important, but actually it doesn't show the value of its evidence-based ratio. And there are two divisions in a treatment study. It might be a treatment study or randomized trial. If it's not a randomized trial, then it's automatically downgraded as evidence. So in many of the guidelines, I generally get the information from NICE guidelines, for example. There are no studies that is non-randomized trials. All of them are randomized trials. Well, if it's not randomized, then it's not seen valuable in that kind of journals. Observational studies, as you can see, if there are special advantages, it can be upgraded, but generally this is not the case. When we look at the non-randomized trials, what are these? There might be experimental studies. They can give high quality, they can provide high quality data, but it's automatically downgraded for limitations in design. Well, case series, they have a very low quality evidence, and expert opinion is not a category of quality of evidence. So 500 people, I mean, it actually in terms of evidence they don't mean anything at all. Well, in grade we have 4 levels of evidence, as you can see. If it's high, the effect size is seen, and we are very confident that the true effect lies close to that of the estimate of the effect. And moderate, as you can see, there might be a significant difference, and in very low there is a very little confidence, and there is a substantial difference between them. So this is in Turkish, but let's continue. Well, the low quality result doesn't necessarily mean that it cannot be recommended. As you can see in the grades example, well, there are high level of evidence regarding different coagulation efficacy is equivalent, but on the other hand, there are some low quality evidence that indicating that some factor inhibitors can be actually detrimental in pregnancy. So the high suggestion actually it says that the factor inhibitors cannot be used in pregnant women, but these are the expectational cases. So when we have a randomized control trial, why it's downgraded? What is the process? We have 5 reasons. 1 is a risk of bias, 2 inconsistency, 3 indirectness, 4 imprecision, and 5 is publication bias. Well, in terms of autism, when we check the studies, the most important problem is the curve, because in psychosocial development it's very hard to get the curve, because we needed the double-blinded, randomized trials, and these are the reasons that the downgrade occurs. Well, the expectation is not actually realistic, you may say, because I mean, how can you do the curve on parenting, for example? And the grade system responds that this is not my problem, this is your concern. Another problem is that the lack of allocation concealment. If you want your study to be high graded, you need to explain your randomization in detail. When you talk about randomization, these are the patients' names. For example, Özgür Öner and Reyhan. And if you are doing this this way, and if the patients know, then it's not a real randomized study. And the third one is actually not telling everything. Because one group of researchers says that when you are planning a randomized control study, I mean, I think it's required in USA, right? We have a website, and it needs to be recorded on that site. If you record it on that site, then I will have a look at it. And if you say that I'm going to do a study on autism, and the aggressive behavior will be on the checklist, and it says that you need to explain it clearly on your publication. And these are the reasons of downgrading. And in terms of inconsistency, it's a practical one, and it's, I think, very easy. When you are reading meta-analysis, we have a statistics that is required on meta-analysis. It checks the homogeneity and heterogeneity rate of a meta-analysis. If it's 98 or 99, and there's a question mark, because the average rate is actually accumulated to one side more. So I think the statistics are very important. Another problem of inconsistency is that the safety intervals, I mean, if it's wide, then it's actually a poor result. If the interval is wide and if the gap is wide, then there is an inconsistency. Well, indirectness means that I didn't see it directly, and if I see, for example, if the result is less, and I think it works in that treatment, it might be a reason of downgrading, because there is not a clear distinction or clear explanation. And another thing is imprecision. I mean, the optimal information size is important, especially for continuous outcomes. I mean, the patient's number of important, and that's why we need meta-analysis. So what does that mean? I did a very good randomized control trial, but my sample size, if it's 40, if it's not repeated by many times, it doesn't mean anything in terms of evidence-based, but it's meaningful in terms of the study itself. The selective publications, I have actually 60 scales, and one of them is significant and others are not. It's very important to note. While giving general views, what is the challenging behaviors? Well, including self-injuries, severe levels of habitual behaviors such as racking and headbanging, physical aggression, destruction of property, and aggression of any type. When we look at the evidence-based modalities in terms of treatment, we know that there are two evidence-based drugs. One is a more possible one, and the others are more on the side of behavioral therapies. You need to know the behavioral methods to have a success in terms of challenging behavioral treatment, because these are the main recommendations, because there is always something that actually strengthening some kind of behavior. Some families say that there are no reason for the destructive behavior, for example. This is not the case. This is impossible. If we cannot see a specific intensifier, then there is a underlying one. We have a positive intensifier and we have a negative intensifier. It's the avoidance. It's not a punishment. It's actually increases that behavior. Well, if I yell at someone and then I'm not included in the course and I'm out of the course. So what is the internal one? I have a stomach ache and I hold my stomach. Well, this is an intensifier because actually it decreases my pain. So what is the positive? I have the less stimuli and I actually bang my hand towards the wall. And actually the intensifier has 4 types, as I mentioned. If we have an increased challenging behavior, it might be triggered by sensory phenomena, or it might be internal and related to the family, or there are external sources. Actually, impossibility increases the risk in some certain psychiatric disorders. And we need functional behavior analysis. This is a must, and we have various methods. We have a formal behavioral analysis. It's pretty challenging to do that because the recommendation is that with the episodes of 15 minutes, it might be 40 or 50, you need to assess the episode and you change one aspect of the episodes. Sometimes you manipulate the environmental stimulators. And as you know, we have A's, B's and C's in the treatment. We have consequence, we have the behavior itself, and then we do not see the fragments of that behavior. It's impossible to evaluate the behavior fully. We need to see its underlying cause, and then we will have an alternative treatment modality. I would like to give you some examples. How is the evaluation process? With dance, behavioral therapy and drug therapy is combined, and the other group is just the drug therapy. And on the right side, EIBI versus parent training is compared. You can see the yellow ones. These are the most important aspects. On the right, when it says the dance one, and it takes up to 2,000 hours, and in the control group it's up to 200 hours. This is the support, and the actually follow-up period is 5 years. There are 28 people, but the follow-up process is long. But unfortunately, in terms of quality of evidence, it's low and it's downgraded, and I think it's very unfortunate because there's a very long follow-up process, but they call it low. It's just one study, there are no other studies, and that's why it's automatically downgraded. And the other problem is that this is not a blinded one. So if you are designing a study, the most problematic aspect of it is, well, if you need to ask and you need to interview with the parents, then it's automatically non-blinded. Well, unfortunately, it's always very low. Why? Because there is a serious indirectness. Well, I included this one. It's a HBOT treatment. There are 2 randomized control studies, so it's included in the guideline, and its effect is not significant. It's not efficient, but there is an increased risk of barotrauma, so it says that it's not recommended. And the other one is the omega-3 fatty acids versus placebo, and it's non-significant, but it doesn't have an effect. So you can do it, but it wouldn't work, it says. And before the drugs, what is the actual recommendation? You will check, you will assess the factors. There might be impairments in communication, there might be physical disorders, there might be changes in the physical environment such as noise and lighting, the social environment, the changes to routines. It's very frequent, and the children gets agitated. We have puberty, we have exploitation or abuse. Sometimes the children is abused at the school, for example, and there is an inadvertent reinforcement of behavior in that people. We should always check these factors. So what can we give as a treatment, and how can the parents support this system, and how should we actually change that environment? Can we change the school or training? If we cannot change it, what can we do? What are the other options? These should be evaluated, and after the assessment, we need to treat the coexisting situation. If your assessment shows a hyperactivity disorder, then treat it. If it's depression, treat it. And after that, if train the parents about it. We were talking with my colleague, and we see actually very insufficient results in the studies. It changed the physical environment, and you need to check the nature of the environment, and you need to assess the family preferences. And lastly, the functional assessment should identify factors that trigger the behavior, patterns of behavior. What are the needs that met? But if you do not assess these factors, in practical life, we do not have a look at it. The medication interventions do not work. And in time, if we add a medication, the other physician actually suggests another one. Some add Seroquel, for example. This is a huge list. Sometimes they use it with a combined form, and the family generally says that whatever drug I use, it works in the first month, but after that it does not work. There is no improvement after all, because we do not know what how a behavior works. In a pharmacological intervention, we should start with the low dose and increase it slowly. You need to specify your target's behavior. If every time I yell, if my mother gives food to me, and I think it wouldn't work at all. The medication wouldn't work at all in that kind of situation. So your expectations from the drug is that the drug actually lowers the general irritability. So actually expectations should be more realistic. The drugs change the sedation. If you do super sedation, then we can actually apply general anesthesia so there won't be any behavioral problems. So, okay, I'm skipping this. Normally, how do we do a functional analysis? We have 4 groups. One of them is being alone. The patient is alone and you observe the patient. And the other one is the attention. In the situation of attention, the patient is playing with something, you are with the patient, and you are indifferent to patient. You see the results, and once in 30 seconds you demand something from the patient, and you check the results, and lastly the patient plays, an observer takes away a preferred item and gives a less preferred one, and you check the control condition. And there are 20 or 30 cycles, but we cannot do it in our daily practice. We have 90 minutes of assessments, and some systems only change the precursors and antecedent events. Well, sometimes it can cause a challenging and disruptive results. So you need to look for, I think, all of these definitions online. But before I am exposed to challenging behavior, I will be talking about N-acetylcysteine, because we have evidence that it can be effective. And lastly, actually, the number of people required for treatment is pretty low. For example, for risperidone, NNT is 2. There is a high efficacy level. And when we check the adverse events, I think as you can see in the clinic, actually the other, when we compare the both, risperidone actually causes less weight gain. Well, this is an interesting study, but I don't have enough time. Later on I will be talking about it. And this is a randomized placebo double-blinded study. Well, later on, if we have time, we will be talking about it. Thank you for your patience.